Aster Women and Children Hospital, Whitefield. So this is a session about placenta. So all of you would have heard about the word placenta. Whenever you go to a doctor's chamber, the doctor generally discusses after the scan, basically, you would have heard about placenta. So what is a placenta? So placenta is, in Telugu we call it as Maya, Mayavi, in our Mavi. Okay, in Kannada we call it as kasa antare kelakade masa chila anta heltare. Tamil vandu adu nanjakodi appdin solvaanga. So that is placenta. So what is a placenta? Placenta is the interface between the mother and the baby. So the placenta is the one which generally supports the pregnancy or supports the baby rather. So from the mother to the fetus, so the uterus is the one which holds the baby, and inside the uterus there is the placenta. The placenta is the one which allows the blood supply to come into the cord. There is a cord and then the baby is connected to the cord. So placenta is very, very important. So what is its work? What does it do? It generally allows it doesn't allow the uterus or the body to reject the fetus. That is one thing. It helps in the baby being stuck there and it allows the baby to grow inside. It also transfers food to the baby, or rather oxygen, blood, everything is coming from the placenta to the baby. So from the mother there is a connection. That connection basically is the placenta. Okay, it also transfers the waste material from the baby back to the mother so that the mother can push it out. So the carbon dioxide and the other waste materials come back from the baby and then they get excreted, right? So it also secretes hormone. Placenta also secretes hormone which keeps the baby going or the pregnancy going very smoothly, right? So Telugulo dini Maya antaru, lekapothe Mavi antaru. Kannadalli adu Masachila illande Kasa antare, because where I studied somewhere in Kolam they used to call it as Kasa, and then in Tamil it is called as Nanjikodi. So that is placenta, right? So generally when you go for your ultrasound or your scan reports, when you look at the scan reports, you will be seeing that the placental positions, it is anterior, posterior, fundal, low-lying. There will be some, these are the terminologies which they would have used for the placenta. So during discussion after the ultrasound, sometimes your doctor may be saying, okay, you have an anterior placenta. So what does it exactly mean? That means when the uterus is, the placenta is stuck to the anterior surface of the uterus, and some here generally anterior, posterior, fundal does not make much of a difference, but we somehow feel with the anterior placenta the movements may be felt a little later. Other than that, it does not have any implications, right? So usually what we are more concerned about is the low-lying placenta. So what exactly is a low-lying placenta? I am very sure most of you would have heard this word, low-lying placenta. So the uterus has a cervix. Cervix is the opening, or it is the one which holds the baby. So the cervix is the one which holds the baby, and when we are talking about the placenta, we are the position of the placenta, we are talking in relation to the cervix. Now, when the placenta is about 2 centimeters from the internal os, that means the internal opening of the cervix, that is called as a low-lying placenta. So generally when we comment about the placenta, we do it at around 20 weeks of ultrasound, that is the anomaly scan. At that point of time, we talk about the low-lying placenta. So if it is less than 2 centimeters or very close to the internal os or the cervix, we call it as a low-lying placenta. But when it is lying on the placenta, when the placental tissue is lying on the cervix, then it is called as placenta previa. So low-lying placenta is different and placenta previa is different. So if the doctor has told you it's a low-lying placenta at 20 weeks, that means it is less than 2 centimeters away from the internal os, but it will move up during the when the pregnancy keeps moving forward. So when we look at it at 20 weeks ultrasound, when we say it's low-lying, we tell you a few precautions. Basically, we ask you not to strain too much. We don't want any constipation. We don't want you traveling or straining yourself too much. This is what we tell you when you have a low-lying placenta. And sometimes if the doctor thinks it's too close to the internal os, she may even give you certain progesterones or medications to keep the uterus a little quiet. So that is low-lying placentas. So you may bleed very occasionally. It's very rare to bleed with a low-lying placenta. In case if you bleed also, it may be just 1 or 2 drops or a little bit of bleeding. But whatever be the bleed, you know that it is the cause of the bleeding is the placenta, which is migrating upwards or moving upwards. So you may have to report back to your doctor. But when it comes to placenta previa, that's completely different. That means the placenta is situated on the internal os. Here the bleeding is quite frequent, and you will have, we do expect the bleeding to happen as and when the placenta is moving up. The bleeding is supposed to happen, it keeps happening more. So the placenta here, again, it is, we call it a placenta previa, and it can be anterior placenta previa. That means when the placenta is stuck to the anterior part and it is on the internal os, and posterior placenta previa. The most problematic ones are the anterior placenta previas, because you may have more bleeding. We may end up with a cesarean section, and during cesarean also it's a little difficult to negotiate the anterior placenta because it is sitting where we perform the surgery. It's exactly sitting there. You may bleed a little more than normal. So the placenta previas, basically the anterior placenta previa, if you had a previous cesarean section, and if it's an anterior low-lying placenta or a placenta which is on the lower part, we just take a note of this and keep watching you how this placenta moves up. So previous cesarean section with anterior placenta and that too low-lying, we keep you under watch. Whether the placenta is going to move up or not, we keep watching. So what causes this placenta to be on the lower side? What causes the low-lying placentas? Low-lying placentas, as I said, they are not pathological, it moves up. But placenta previous, that means when the placenta is sitting on the cervix, it can be because of the previous cesarean sections, it can be multiple pregnancy, that means twins or triplets, it can be aging mother. So the more the number of pregnancies, then certain times you have a placenta previa. Fertility, if you have gone through fertility treatment or previous surgeries on the uterus, all this can cause the placenta previa. That means the placenta which is lying down on the cervix. So here the bleeding is generally painless. You will not have any pain, but as I said, the first bleeding will be smaller. The second bleeding will be much bigger than the first episode. The third bleeding may be torrential bleeding. So when it is placenta previa, we do also expect, we have to keep an open mind about about cesarean section or surgical deliveries and preterm deliveries, and staying closer to your hospital is very, very important. And sometimes you may even have blood transfusions at this point of time. Okay? The doctor may even suggest blood transfusions. So sometimes we use the word called placenta accreta. So previa is different, placenta accreta is different. So placenta accreta is when the placenta invades the myometrium. That means the layers of the uterus. Uterus has got multiple layers. So the inner layer is the endometrium or the decidual layer during pregnancy, and the next layer is the myometrial layer. See the muscle layer of the uterus. If the placenta invades or bites into that part, it is called as placenta accreta. So it's called as placenta accreta. So here it's kind of risky because the placenta is nicely gone into the uterus, and it's very difficult for it to come out. Suppose delivery, generally the placenta separates itself and comes out within half an hour to 45 minutes. By 5-10 minutes it comes out, but maximum we can wait is till 1 hour. It usually comes out on its own. But here in placenta accreta, the problem is it would have invaded the uterus. Sometimes it invades the adjacent organ, that's your bladder also. So we call it as accreta, percreta. We have different names for it. So here it's quite risky for the mother also. Sometimes you may end up with cesarean hysterectomies. That means the uterus may also be removed after the delivery of the baby if we are not able to control the bleeding. And sometimes the adjacent structures it would have invaded. Here, most of the times, the placenta accretas are due to previous cesarean sections. The more the number of cesarean sections, the more the chances of placenta accreta. And previous hysterotomy scars and all this stuff can cause placenta accreta. So here is basically bleeding, and as I said, hysterectomy can be a possibility. So it is a little risky for the mother. This is one condition when we have a placenta which is on the anterior surface, which is towards the previous cesarean scar, and it is showing some mixed signals. We always get an MRI done before your delivery to plan the delivery. If the MRI will tell us clearly whether the placenta has invaded the myometrium, into what depth it has gone, what to expect. So we keep things ready before we go for delivery. So sometimes the doctor will ask an MRI or during your last trimester of pregnancy when we have a suspicion of placenta accreta. And then there are certain other conditions of placentas that, like, the doctor may say it is a circumvallate placenta, or it can have vasa previa, where the blood vessels flow, they are on the cervix. So there are different kinds of vasa previa, velamentous insertion of the cord. That means the placenta, the center of the placenta is where the cord arises. Sometimes it can be attached to the edge of the placenta. So there are these conditions are there which can sometimes be found by the ultrasound, and the ultrasound is the diagnostic procedure here. And there are different other kinds of placentas, like a succionate lobe. That means an extra small lobe of placenta. Other than your placenta, there's a small part of placenta which is just a little far away from the regular placenta, but it is stuck over there. It comes out post-delivery, but sometimes it can be inside, and if we had not diagnosed it before our before the delivery process, we would not know that it is sitting inside. Generally, it comes out post-delivery, but sometimes it may be inside, and then post-delivery it can cause PPH. That means postpartum hemorrhage. You may have a little more bleeding, and then we get a scan done, and then we find that there is a little bit of placenta there. But if you look at the regular placenta, everything would have come out, but this is an extra lobe which we had not picked up during the ultrasound. Sometimes it's not possible to do it, so it must have been there, and then we remove it later. So they are sometimes called as duplex placentas. That means two different placentas actually, but there's a single baby. So this is called as duplex, bipartite, tripartite. There are different kinds of placentas. So the bigger the surface of the placenta, then what do we expect is a little more bleeding post-delivery. So we call it as postpartum hemorrhage. That can happen. So we prepare ourselves mentally to keep, and we also prepare the patient and the necessary things like blood transfusion, whatever is necessary, and keep things ready for emergency purposes. And what is an abruption? So you would have used the word called, you would have heard about the word called abruption. So when I said about the bleeding in placenta previa, there it is a painless bleed. Mother will not feel any pain. But when it comes to placental abruption, that is the separation of the placenta after 20 weeks of pregnancy. It can be partial or it can be complete, right? It just separates itself from the uterus. That is called as placental abruption. So here what happens is the placenta separates. If it separates partially or completely also, there's a lot of bleeding that has happened inside, and it is very painful for the mother, and the uterus is very tight and irritable, and this happens after 20 weeks and before the delivery process. So sometimes we lose the babies inside. If it's a complete abruption, we lose the baby inside, and sometimes the coagulation factors go into a play, and mother can end up with disseminated intravascular coagulation, that is called as DIC, which is a very critical condition for the mother. So where does this happen? So it can happen, what are the risk factors? Basically hypertension, that means blood pressure for the mothers, preeclampsia, eclampsia, hypertension. These are the conditions where we can expect abruption to happen. In smoking, pregnancy related kidney injury, if there is any problem with the kidneys because of pregnancy, so there, and sometimes uterine anomalies also can cause, and then in case of smoking, and sometimes, very rarely, in anemic patients also it can happen. So you may see the bleeding or you may not see the bleeding. That is again two types. One, it is called as concealed. That means you will not know that you have blood inside or the placenta has separated itself. You will only have a severe pain abdomen and a very tight uterus. So you will be coming to the labor room with a pain. So that is a concealed. When we get a scan done and when we assess, we will know that that you have had an abruption. But we already risk factors are there, so clinically we can diagnose an abruption. Sometimes it is revealed. That means partially it is separated, or you will start bleeding out. The fluid also becomes blood tinged and blood colored, and then you start bleeding out through the cervix, through the vagina. So that is called as revealed abruption. So here it's an emergency. We try to, very mild abruptions, we try to wait. We can wait and we can even give a normal delivery. But when it all depends on your degree of separation, how much it is separated, how the fetus is doing inside, and what is the hemoglobin of the mother, how the mother is coping up with the situation. We decide what to do for the mother, whether it's going to be a vaginal delivery or whether it's going to be a cesarean section, right? So, but if the placenta or the separation of the placenta exceeds about 50% or more, then patient has a fair chance of ending with coagulation disorders. That is BIC, we call it as. Then we would have spoken, and we also would have heard about something when we go to the OPDs called as placental insufficiency. The ultrasound doctor or your regular obstetrician would have spoken that the placenta is not supplying good amount of food to your baby, or it is not allowing the blood supply to the fetus. That is called as placental insufficiency. Here that also may cause blood pressure to you, hypertension, and it may cause smaller babies, not the lengthwise, but the weight can come lesser. The fluid around the baby can come smaller. So why does this placental insufficiency happen? As I told you, this is the main organ which supplies food to the baby. So when the placenta, how does it do is it fixes itself inside the uterus. So rather we call it in medical term, it invades the uterus, the spiral arterioles. There are arteries in the uterus, and the placenta invades it and makes them very loose and lax, so that the blood flows in from the uterus to the placenta very freely. If there is a defective invasion of some of the spiral arterioles, it does not, the placenta does not get itself stuck properly, or does not allow good blood supply to the fetus. So that is where you start ending up with placental insufficiency. So when it comes to placental insufficiency, it can cause preeclampsia. That is, you may develop blood pressure, you may develop a smaller fetus, or sometimes this can happen very early in pregnancy. That may be because of infections also. It can happen a little late in pregnancy, that at that time, can we detect this? Yes, sometimes we detect it at 12 weeks or 20 weeks, and we start you on medication called as aspirin to aid the process of allowing the baby to have good blood supply from the placenta. So this is about placental insufficiency, where we take, that is also checked during the 12th and 20th week scan, and this is that's very important to get your 12-week scans or the 20-week scans. That's where we pick the Dopplers, or we predict that yes, this can go for placental insufficiency in future in the pregnancy. Then what are all the other complications which we can face because of the placenta is retained placenta. That means post-delivery. Once the baby is delivered, then it may take, as I told you, maximum time we can wait for the placenta to come out is for 1 hour if she is bleeding, not bleeding, and if the patient is coping well, and we can wait till up to that time. We will be giving certain medications for the placenta to remove itself and come out, and the uterus to contract well, so that the patient does not bleed out, right? So here sometimes, no matter what we do, the placenta can get stuck, okay? It may not come out as we expect. So that is called as retained placenta. So the reasons could be previous surgeries or previous DNCs. When we do a lot of scraping of the uterus prior, the placenta may get stuck. and you may start bleeding very profusely post delivery, but the placenta may not come out. So there are two ways of doing things here. We keep blood ready. First we try with the medications. If the medications are not working, then we try manually removing the placenta. So that can be done, that has to be done under anesthesia, so that you're sedated, you're completely fine and relaxed, and then we remove the placenta. So that is called as the manual removal of placenta. Sometimes it may not be possible to do that, and we may have to go and surgically evacuate the placenta. You may bleed very heavily, and sometimes we even if you're not bleeding and things like that, there are other procedures where we leave the placenta inside for it to separate at a later stage and come out. All right, we give certain medications for it to die down and come out. So these are all the things which you should know about placenta. So hopefully you understood what the placenta is and how important the placenta is for the pregnancy, and the complications surrounding it, and how to deal with it. So thank you very much. Hope this was very helpful for you guys. Thank you so much. Thank you.